Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome everyone to our weekly webinar series on the medical and public health considerations of COVID-19. Today we have a very special session on designing an effective and efficient system for distributing COVID-19 vaccines. Next slide. I'd like to thank our webinar series partners for helping to get the word out to various societies about our webinar series. So very much appreciate it. Next slide. This webinar will be recorded and will be available for on-demand use on our website starting on Friday. The registrants today will get a notification about this, and feel free to also view our previously recorded webinars as well. Next slide. We also have a series of web series FAQs for many of our webinars, and these can be accessed on our website as well. Next slide. There'll be a Q&A in the last 15 or 20 minutes, depending on the question. Sometimes we go over the hour for a few minutes as well. We look forward to the questions. Please type them into the Q&A box or the chat function during the presentation. Next slide. Our speakers do not have any conflicts of interest to disclose. Next slide. Today, well, actually tomorrow marks 365 days since the global pandemic was first declared. Since that time, there have been over 117 million cases globally, with 2,600 deaths from COVID-19. In the US alone, there's been almost 30 million cases and 526,000 deaths as of today. This webinar series has been an attempt to provide the latest information to our attendees about all sorts of components to the COVID pandemic. We're very appreciative of our faculty who've graciously volunteered their time to push out the best scientifically based information. I'd like to thank my co-moderator of the series, Dr. Ziad Kazi, who's a board member of the American College of Medical Toxicology and president of the Middle East and North African Clinical Toxicology Association. Next slide. At this point, I'd like to introduce and turn our webinar over to our guest moderator. Dr. Robert Gugule is the former vice chairman of the National Advisory Council and works for FEMA, and also former director of the New England Center for Emergency Preparedness at Dartmouth College, Geisel School of Medicine in Hanover, New Hampshire. At this point, Dr. Gugule will introduce our speakers for today. Thank you very much.
Thank you, Dr. Wax. I'd like to thank the ACMT for the opportunity to present this important work at today's webinar. Today's faculty include Dr. Nathaniel Hubert, Associate Professor of Medicine at Weill Cornell Medical College in New York City campus, co-director with Dr. Muckstadt of the Cornell Institute of Disease and Disaster Preparedness in New York. Dr. Michael Klein, Assistant Professor, Department of Marketing and Business Analytics, Lucas College and Graduate School of Business, San Jose State University, San Jose, California. And our primary speaker this afternoon is Dr. Jack Muckstadt, Professor Emeritus, School of Operations, Research and Information Engineering, Cornell University, Ithaca, New York, also co-director of the Cornell Institute for Disaster and Disease and Disaster Preparedness. Jack, would you like to go ahead and get started?
Thank you. Thank you for everyone to invite us to give this presentation. So let's begin. And this address we're going to have is really about several questions. And these questions will be the key for everything we will discuss. So first, the question is, what should the vaccination strategy be? How should we actually approach our distribution policies? how should we think about achieving this through some alternative supply chain structures? And should we, as we go through the distribution, should some supplies be held back, or should we just move them forward? Or how can we tell? Is there any mathematics, for example, that might guide us when we think about this? And then lastly, and perhaps as importantly, is how many sites should there be in each state or jurisdiction? And how will the number and size of these sites affect our ability to achieve some objective? So these are the questions that we're going to have. And then the question is, can any science besides medical science assist us when we're addressing these questions and perhaps many others? So let me begin by saying that while mathematics can be important, there's really an overarching set of issues that must be addressed when you design a distribution or allocation system. The first one is you got to have transparency. Everybody has got to know the need and impact of every decision that's being made. That means we have to have information flows that are going to permit us to understand what is happening at each part of the system that we're managing. We also have to ensure that it's fairness, and so that that people in each geographical region and each of the subpopulations that we have are going to be, in fact, serviced properly and equitably. And then finally, we must have accountability. And I see that I went one too quickly here. We need to have accountability, and we have to ensure that the consequences that we have that are going to be observed every day at every level of the supply chain. And in order for all of these three things to occur, we need to, in fact, then think about what it is that our objectives are going to be. So what are our objectives? What should our objective be? So I think the one, if I were to ask you what the goal should be, I think everybody would say, well, maximize the number of vaccinated persons. But I think you need to think about what that means. So let me just give you two examples. So President Biden has came and said in 100 days, we'll vaccinate 100 million people. But let me give you two absurd examples. Suppose on day one, we could vaccinate 100 million people, and which of course is not possible, but suppose we had vaccinated 100 million people on the 100th day. So we would have achieved the goal that President Biden has stated. But we can see that people, if they're vaccinated earlier, have a distinct advantage for them individually as well as from a societal perspective. They will not be able to communicate, they will not infect other people. They will also be less likely to become ill themselves. And if they do, they will not likely end up in a hospital or die. So there's another measure that we must have. And that measure is what I'm going to call vaccination person days. In other words, we want to get as many for each person that we vaccinate. We like to get them vaccinated so that they are vaccinated for a long period of time. So a person vaccinated today has one more vaccination day or vaccinated day than a person who is vaccinated tomorrow. And that person has more vaccination days than a person who is vaccinated subsequently. Now, ultimately, the question is, what does this whole distribution system have to look like if we're going to maximize the number of vaccination person days? So let me step back for a moment. I've been looking at supply chains for better than 5 decades, and I've looked at them in a variety of industries. I've looked at them as a member of one of the board of scientific counselors of the CDC. And I've just, over this period of 5 decades plus, I have gotten a set of fundamental ideas about how supply chains ought to operate. And I call these 5 principles. Now, these 5 principles, I've sort of slightly worded them so that they apply to vaccine distribution, but these principles apply in every environment. The first thing and the most important thing is to ensure that you've taken the patient's requirements into account and how those patient requirements are going to be satisfied by, in this case, the people at the end of the system, which are the vaccinators themselves, and the environments in which these vaccinators are going to operate. The second one is that you're going to need to have an organization that moves material through the system rapidly and without wasting either time or having losses of the vaccine due to poor management of the supply. The third one that you want to have, now you can't have a system that is transparent, is fair, and is accountable if you don't have information that is available to each element of a supply chain. And that means that you need an information infrastructure that is going to collect, process, and distribute information, not just vaccines, but information rapidly and in a timely fashion throughout every entity that's in the supply chain. But information on its own is only of limited value. You have to have processes in place, management processes, administrative processes, medical best practices that are going to operate so that you can take advantage of the information. But if you've got the processes, you have to actually activate those processes. And activating the processes comes only through having rules or decision support environments that produce decisions for making the allocations and other decisions in a timely way. So you need all of these. So let me just view this picture a little differently. And I've just arbitrarily said, we've got a system that consists of what I'll call 4 layers or echelons in the system. And material moves through these systems eventually to get the vaccines to the patient. So we have information flows. The little boxes that you see in these circles are indicating processes that go on at each one of these ones. So all activities are a collection of processes. Something that happens, somebody tells somebody to do something, and what the somethings are processes. Move this, do that. So you have information that's flowing. You have the processes themselves, which interact from location to location. And then you have the information infrastructure that is used to disseminate the decisions that are made at each place. And you can see the arrows go in both directions in this picture. So information flows, everything occurs, and it occurs over time. And time is the key, because if you take a long time to do all the things, then you cannot be effective and you cannot be efficient. Just remember, an efficiently designed system that is implementing policies that are not good ones will not result in the desired outcomes. Effectiveness and efficiency are not synonymous. So let's, too much activity at one time here. Okay, so let's address one of the questions that I posed earlier. And you'll notice that this talk will be nothing but a series of questions and then answers to those questions. Okay, so let's assume that we're dealing with the Moderna or the Pfizer vaccines, each of which requires 2 doses. And then the question that comes up is, should we hold back on some of these? Is it possible that we should hold some in reserve and then wait so that we have basically a probability 1, if you want to call it that, that we will have the second doses available at the time that they're needed? And the answer to that should be no, don't do that. And what you should do is administer the largest possible number of first dose shots as possible in every given day and hold nothing back, and just make sure that you hold back only things at the point in time that ensures that you have the second dose requirement. Now, let me give an example of how this might work. Suppose we have two warehouses that are run by a manufacturer. And let's suppose, for the sake of argument, that over the next 26 weeks, that this first warehouse is going to be each week get an increasing amount of supply from the manufacturer. And the second warehouse is supplying not only US market, but the Canadian market. And at some point, some of the supply that's being produced is going to be diverted to the Canadian market. Now, the question is, how many first and second doses should be optimally administered each week for each of these warehouses? And then the secondary and important question, is it ever necessary to hold back some doses? And we're going to see the answer to this. And let's just, for the sake of illustration, assume the time between the first and second doses is 3 weeks, which is consistent with the Pfizer vaccine. So let's look at this picture that we have here. You can see manufacturer 1. If you look across here, every week, the quantity that is available to distribute from manufacturer 1's warehouse is increasing. And it increases for number 2 for a while, but then starts to decrease. Well, let's just suppose, for example, for manufacturer 1's warehouse, that instead of using all, let's say these numbers are all in thousands. So we have 2 million doses that we have available at manufacturer warehouse number 1. And suppose we held back 1 million of these doses so that we could administer those second doses to the people 3 weeks later. So let's see what the consequences might be. So let's see. Let's sort of conceptually think of every person in the United States that wants to get vaccinated gets in a line. So there's a first person, a second person, and everybody's in this line. So if I follow the strategy where I'm going to hold us back, the first 1 million people in this line step up and I vaccinate them. The second 1 million, everybody will move up now in this line, and then in the following week I would vaccinate more people, but I would hold some back. So if I think about the 26 weeks, I had 1 million people who were in line that did not get vaccinated in that first week. So each one of those persons lost a week's worth of vaccination. On the other hand, if I vaccinated all 2,000 or 2 million people in the first week, all of them would have had that week, and I would have had a total of 26 weeks worth of vaccination periods. Well, so if I postpone, I lose vaccination periods or days or weeks, and that is not going to yield the best solution. So, and I will illustrate this further as we get farther into the talk. So let's take a look at what the consequences of this type of plan. So again, we have increasing quantities of available supplies. So are the first doses going to increase because we have an increasing supply? And what happens in the second one? This is because we have something that drops down. Does it drop down only because in first doses, because we have a lesser supply? Let's see. Okay, so we see that in the left-hand graph here, we see there are 3 lines. This line that I'm pointing to, we see that you have a nice increasing total number of first and second doses. The red line that you see here that goes up and down is the first doses that are administered in each week. The second doses are the blue lines that you see here. Now you'll notice, of course, that there is sort of a phase in here. You start increasing, then decrease, increase, decrease, increase, decrease the quantities of either the first or the second doses. For the second warehouse, the total number of doses administered doesn't go up nicely. It goes up, it goes down, shoots way up, shoots down. And then again, you're getting this sort of out of phase kind of, but more ups and downs as a consequence of the variation in supply. So let's look at the second one a little more closely. This goes up, it goes down, but notice right here on week 24, we have no first vaccinations. Now, let's see, on week 24, we have 4 million doses that are available. If we step back and look 3 weeks prior to that, we will see that we actually gave vaccinations to 4.2 million people. Well, why, if we ran out here and did not have enough, namely 200,000 doses, why didn't we just shut back the, why didn't we just have fewer doses distributed here? Well, the answer is that we wanted to maximize the number of vaccination days or weeks that we would like to have for our population. So rather than not vaccinating as many people here, we in fact vaccinated first time fewer here. And what that did is it gave us 2 incremental weeks for 200,000 people, and 2 weeks, let's say 14 days, times 200,000 people is an incremental 2.8 million vaccination days that would occur if we postponed the, if we had not postponed the administration initially, but waited to reduce the number of first doses to week 23. Okay, we're going to come back and we're going to see that. It's a subtle point, but the whole idea is to try to get as many first doses in people's arms as possible, consistent with our requirement to get second doses. So Nathaniel, I'd like to turn this over to you and give you an opportunity to comment on what I've said so far, plus any other thoughts that you might have.
Great. Thanks, Jack. First of all, I want to just say that it's a real honor to be on this webinar. Thank you to the American College of Medical Toxicology. It's also always an honor and a privilege to be on the same stage as Jack, with whom I've worked for the last couple of decades. Every time he speaks, I learn something new. I would just summarize what he said as a really critical change in the way that planning probably has played out over the course of the last 4 or 5 months in this country. You know, a lot of the vaccine distribution planning happened in September and October when CDC had some requirements from state public health officials. We have a federal system of public health, so each state was able to make its own plan. And a lot of those plans, I'm sure, looked at this and said, this is a complex chessboard or a puzzle, and we have to put all the pieces in place so that we can match up supply and demand the best that we could. Of course, no one really knew what the supply was going to be, so that was an added complication. What we're saying now is that that level playing field really was the wrong fundamental approach. It's like the playing field is tilted and everything is sliding towards increasing numbers of cases. And the imperative is on us not just to make this vaccination strategy work in terms of matching supply and demand, but to work as quickly as possible. Now, I know people have said this before. What I believe we've been able to do, and when I say we, it's a royal we, because it's really Jack and Michael, Rob, and our colleagues, Peter Jackson and others, the engineers in the group and the mathematicians, have been able to show that this subtle but critical point about pushing everything as early as possible and then making it fit up later is absolutely important. And I'll just say one medical thing as one of the medical doctors involved, Rob is as well. We're now seeing the emergence of variants. Variants occur because we've given the virus the opportunity to vary. The better we can do about getting more people vaccinated earlier, the less of a problem the variants will be. This has been written up really nicely in a new piece in the New Yorker. Other people have written about it, but really this is the critical moment to tackle this issue, to decrease the number of variants that are emerging. And if they are out there, to limit their ability to spread. I'll pass it back to you, Jack.
Okay. So the question now is, we have sort of thought about what I would call a global strategy, that is, that we want to maximize the number of person days. But how does that operationalize? How do we get into a day-by-day kind of strategy that we should employ? Now, there are various components to the day-by-day strategy. And one of them is, well, how do we organize people to get the vaccine? So this is a picture when I was on the science board of one of the Board of Scientific Council of the CDC. I was interested in the vaccine distribution for the swine flu. And you can see that people are lining up to get this, and there's only one person that I could identify in here that was in a mask, but it's a clearly a not well organized way, and it's most likely going to help the spread of the flu. But the question really is, did we learn anything? And you can see that while people are wearing masks, we're still crowding up, and so we really need to make sure that we think about efficacy, and we think about trying to make sure that we're doing this correctly. We need to look at all phases of the system so that we get the desired outcomes. Now, let's look at a couple more questions. One of the questions comes about, if we're going to have transparency, fairness, and accountability, and we're trying to do this in a way that is going to be efficient and effective, how many vaccination sites, which we're going to call vaccination administration sites, should there be in each jurisdiction or state? And furthermore, the question is, does it make any difference in terms of the critical outcomes that we're going to be looking at? And we're going to be measuring outcomes in 3 ways. The first way is, how many people got vaccinated? Well, that's a reasonable one. The second one is what I'm going to call a vaccination rate, which is the fraction of people that were signed up for a vaccine actually get something put into their arm. And then the third one is we're going to call missed vaccination days. So the question then, how does the structure of the system, number of locations, size of locations, administration rates, and at these administration sites, how does that work? So I'm going to give you a little story. And this is my experience of what happened. I went a couple of weeks ago, I went and got my first shot at a local pharmacy. There was just one person administering the vaccines, and I had a chance to chat with her. And part of this chat indicated that, roughly speaking, she was doing close to 3 to 4, but mostly just around 25 or so vaccinations per day, and on a couple of occasions she got up to 30. Well, that's kind of interesting. So she also told me that morning she had received 100 doses of the Moderna vaccine. And let's just look through a little story. So if she were able to just provide or administer 25 doses each of the 4 days, then at the end of Monday, after she had administered 25 doses, she would have had 75 left. On Tuesday, she would have administered another 25 doses. She would have had 50 left, et cetera, until at the end of Thursday, she had no doses left. But let's see what this means. So each of the 25 people that's vaccinated on Monday had 4 days of what I'm calling vaccination protection, or 100 in total vaccination person days. So here we are, we got 25 people, and each is vaccinated for 4 days. So that's how we end up with 100. What about the next day? Well, there's another 25, but now they only have 3 days. They've got Tuesday, Wednesday, and Thursday instead of the 4 days, the Monday, Tuesday, Wednesday, Thursday that people had on Monday's vaccination. So in a total then, we had 75. Then we had the people who were vaccinated on a Wednesday. So they just got 2 days of vaccination protections for a total of 50. And then the people on Thursday just had 1 day, if we're just counting for these 4 days. So if we add these 4 numbers, this is the only math in the whole talk, you end up with a total of 250 vaccination person days. Now let's look at another alternative. Suppose we still got all of these 100 doses on Monday and we wouldn't get any more doses that week. But suppose we could have administered all 100 doses on Monday. Then that means that there would have been nothing left at the end of Monday, Tuesday, Wednesday, or Thursday. But all 100 people would have had 4 days of vaccination protection, or 400 is much bigger than 250. Now you say, well, that's okay, it's just one pharmacy. But if you do this at scale, that means lots and lots and lots of pharmacies. What you do is you have a lot of missed opportunities. And the more opportunities you miss cumulatively over time, week by week, week by week, it ends up being millions and millions and millions of missed opportunity days. And that is an issue of importance. Okay, so basically the idea is you want to ensure, again, that you get the shots in people's arms as quickly as you can so you can maximize the number of vaccination person days. So I have lots of maxims. Those who know me know that I have lots and lots of these little maxims about supply chains. One of them is, as it states here, keep your assets in the most flexible form for as long as it's economically and operationally possible. The more you move stuff out of higher echelons down to lower locations, and those lower locations hold on to this material, it doesn't give you the opportunity it doesn't give the opportunity to use the material someplace else. So there was a question came up, what's a vaccination person day? And every day, let's say I'm vaccinated today, every day from here on, I have a vaccination day. So today, tomorrow, every other day, I'm vaccinated. I'm going to count up all of those days. And if I'm not vaccinated until 2 weeks from now, in between now and then, I would not be getting any vaccine. I would not have a vaccination day. So the more days, so mathematically speaking, my objective is to say, well, how many people can I vaccinate today? And then if I'm thinking about 180 days or something, 180 days times the number of people I vaccinate today gives me 180 times that number of people I vaccinated today. That's the total number of vaccination days for today. So tomorrow, well, it'll only be 179 days. So 179 times the number of people vaccinated tomorrow. And then the following day, it keeps going down. So what I'm going to do is I want to get the cumulative number as large as possible, which means I've got to maximize the number of people I'm vaccinating today. So local optimization results in global harmony and disharmony. Now think back a year ago and these two maxims, if you will. What happened? Well, we ran out of toilet paper, we ran out of PPEs, everybody was scrambling to get things, everybody tried to build up stocks of these things, and it created a mess, to put it mildly. So you don't want to maximize in your own way. You need to think about the global impacts of the decisions that you're making in each place. And the system needs to be designed in such a way that that occurs. Now, there's another important thing, and that is individuals can't perform tasks very well unless they do them all the time. And consequently, when we build a system, we have to think about how people should perform what tasks at what points in time so that we can make the system efficient and effective. Now, when we look at the entire distribution system, and I've just outlined it here, there are elements in it of moving material from one place to another. For those of you in supply chains, the time between locations we're going to call lead times. And as it says down there, it's the time between an allocation decision and the allocation decision's impact on the receiving location. When does that occur? Now, if just think of this, material moves. It might move from a vaccine supplier. It may end up in a central spot in the US, but probably not. Probably just gets sent out to states or some regional jurisdiction or warehouse. The length of time that it takes to get that material there is a lead time. But it could sit at the state or jurisdiction for some period of time before it gets sent down to a vaccination administration site too. And when it is finally shipped, it takes some time, the lead time. And you'll notice down at the bottom, it says cumulative lead time. So what we are interested in doing here is trying to move the material through as quickly as we can. And why is that important? Because let's just say if it takes 10 days for something to go through the system, that doesn't sound like very long, but at the rate of production that we have today, which is in the millions of doses per day, you multiply 10 times millions and you get tens of millions of vaccines that are just sitting and not getting into somebody's arms. So the goal is going to be to try to move the material as quickly as possible so we can get more shots in people's arms. So you want to have these lead times to be short, but you also have to have them predictable and repeatable. I've got to be able to do this. And that's why I need a system that is, in fact, one that gets used all the time to move the material. You need to have knowledge of what's going on. Otherwise, you can't have something that's transparent, fair, and accountable. And then you need to make the decisions about how you're going to move them in a way that responds to what you actually are seeing occurring. That means you're going to make allocation decisions each day. And ultimately, you want to make sure that when you move stuff down to the vaccination administration site, you do it in a way that ensures that the material is going to be used very, very soon. So let's just take a quick look at a possible way in which you might deal with the state of New Hampshire, and we've done some thinking about this. So there's about 1.3 million people live in the state of New Hampshire, and assuming that some portion of this population is going to get vaccinated through in nursing homes or adult care facilities or through hospitals, then the remaining about 70% of the population would be dealt with in a more general way. And let's just for the sake of argument here, let's assume that that what we are going to do is deal with something like the Moderna vaccine, which comes in boxes of 100. And that in order just to make the arithmetic relatively straightforward, if we wanted to get to 70% of the population done in a 200-day campaign, it would require us to do approximately 9,800 doses per day on average. So let's, oops, I got it on the wrong side here. So let's look at two alternative ways in which we might distribute this. The first is that we have 9 large dispensing sites and 4 mass vaccination sites with vaccination quantities per day as indicated on the slide of 2,000 or 200. Another one corresponds to, let's say, that we had places like pharmacies, and New Hampshire has somewhat around 200 pharmacies. And if you look at them, they vary in size. You can see some of them I've indicated are have an administration capacity that's pretty small, 30 or 100 or 150, and I've indicated here the number of sites that are associated with each one. Now, some of these, excuse me, some of these sites have some goals, and as I've indicated for the mass vaccination one, you'd have 2,000 a day, but it could range from 1,900 to 2,100. People will sign up, and some will show, some won't show. Some may, sometimes we may be seeing more people show up than we might have anticipated, or we ask more people to come in. But these are the ranges in which we might see for these various size locations. Okay, so altogether there are 13 locations. They're our first alternative, and we have 181 locations. These numbers were chosen in a way so that we would have another variation in this, which has to do with the uncertainty of the requirements in both alternatives, and to make sure that in aggregate the uncertainty is the same in order to run an experiment. So the experiment that we have run is over 180 days, and each day embedded in the simulation and software that we had, we employed an algorithm that took into account the uncertainty that I showed you on the ranges that I showed you on the preceding slide, and we made the allocations in a way that would be most effective. We assumed that there was slightly more than the required amount to meet the expected demand, so which was 9,800, and we put in 10,000 units. So, as I said earlier, there are really three performance measures that are of importance. The first one is how many vaccinations did we actually administer over the time. The second one is how likely was it that people were going to be served that wanted to be served on each day? That's what we're calling the vaccination rate. And then most importantly, as we'll see, the missed vaccination person days. So let's see how the experiments run. I'm going to turn this over to the man who did all the work in writing the software for the simulation and who compiled all the results. So Michael, I'm going to turn this over to you.
Okay, can someone start my video for me? I'm not able to on my end.
You're okay.
Okay, coming now. Here we are. Okay. Well, hello, everyone, and thanks very much. So I'm excited to share some of the results of our experiment. What we've done here is conducted a simulation 500 times. And what we're seeing here is the average results for the 180 simulated days. What we first did is we want to show the results if we had a box size of 1. So this is the idea that you could ship any number of doses of the vaccine could be shipped. If we look at some of these rates that we're seeing, so if you click for a second, Jack, we'll see the average vaccination rates are quite high in both alternative A and alternative B. If we look at the number of vaccinations, they're also fairly high, but higher in alternative A than in alternative B, where we had fewer locations. But now if we look at the missed vaccination days, if we click at this, now what we're going to see is a big difference. It's, as we see here, almost 4 times as large. So the missed number of vaccination person days, just from having, this alternative A, fewer locations, we're going to have a lot less missed opportunities compared to the case where we have alternative B with 181 locations. And so recall that this is with a box size of 1, so it has nothing to do with the box size. Then we also conducted experiments with the box size equal to 100. And so now if we take a look at the vaccination rates, we'll see that alternative A and alternative B, now we see a bigger difference in terms of the rate. So alternative A becomes quite a much higher vaccination rate, as we see if you click, Jack, for a second to highlight that. And then we see our number of vaccinations is also a greater difference between alternative A and alternative B. But if we look at the missed vaccination person days, here we see also a great difference. And this is actually more than 6 times as large. So when the box size comes into play, we're going to see this issue become even worse. if we have too many locations to administer. So if we can go ahead to the next slide. What I wanted to do now is just show you a look at, this is a look at one particular simulated replication of the experience by day, and we look at every day and see how many missed vaccination opportunities there are. So this is the actual opportunities, not in-person days. Take a look at the scale of these two. We'll see that they're quite different, right? We see the order of difference between alternative 2 and alternative 1. It's more than 3 times, right? More than 3 times, and not just over the horizon of our 180 days. But this is something that's happening every single day. So it speaks to the importance of us to manage this every single day. And just to highlight again what this thing that Jack had tried to explain several times here is related to this idea of what are these missed vaccination opportunities or missed vaccination person days. So to think about it, we just think about this as there's a cascading effect that occurs here. Right? So for example, let's say a person could have been vaccinated today and inventory was held at a location and was not used until tomorrow. Well, if that individual could have been vaccinated today, let's imagine that was somebody who is scheduled to be vaccinated tomorrow, right? So that means somebody who could have been vaccinated today instead of tomorrow. And if that's the case, then somebody who could have been vaccinated tomorrow could now be vaccinated tomorrow instead of 2 days from now. And so we have this cascading effect all the way till the end. And so that's why the number of person days will be a dramatic increase. And this is essentially what we're trying to do, right? We're trying to vaccinate people as soon as possible. And so our point is that that should really matter. And we should think about this to be able to generate the best option for from a public health perspective. So I'm going to turn it back to Jack for some final thoughts, and we're very much looking forward to your questions and answer to have a discussion on this.
So as Michael and Nathaniel have said, as well as myself, the overriding goal that we should have is to maximize the number of vaccination person days. And the question, of course, comes down to listening to the science, in this case, the science of mathematics and logistics. And so basically, there are a number of things that the science shows us. Larger and fewer vaccination administration sites is preferred. Holding back the vaccines unnecessarily is a bad idea. There's another thing which we haven't had a chance to discuss, and that in any detail, but you want to also have larger facilities because it requires fewer workers in order to accomplish the task. And that's a function of basically applying some queuing theory to this idea. But again, mathematics can be used to do that. And lastly, and importantly, there's mathematical ways of dealing with the fifth question of my principles, and that is making sure that you optimally allocate things day to day throughout the entire supply chain. I just, in case you're interested, you can get the paper that we have written on this topic, and you can go to this website that's down at the bottom here, http://ssrn.com/abstract equals 3794252. And I think at this point, we'll turn this out to any questions that you might have.
Thank you, Jack. I think we're going to go ahead and turn it over to Dr. Goujolet for some questions as well as some comments.
All right, there we go for starters. And okay, so the first question, Dr. Wax, I think you can go ahead and answer. The people who get trained briefly for only 20 minutes, how confident should we be in them administering the vaccine? Those that get trained have a medical background. Will there be 2 people at least to one oversee the other? So that's a little bit outside the scope of today, but I think that warrants a good answer.
Yeah, good. Well, I appreciate the question. And I've had the opportunity to be a volunteer vaccinator for about 50 hours over the last month. It's really been an amazing experience. So gratifying to be able to vaccinate, many, many people in a relatively quick succession. I've been working over at the State Farm Stadium in Phoenix, Arizona, which is set up to vaccinate approximately 8,000 people a day, with ramping up to, I believe, 12,000 people a day. And as an individual vaccinator, I had the opportunity of vaccinating between 200 and 250 people just myself over the course of 8 hours. The vaccinators have to be clinicians. Many of them are RNs. There are physicians like myself, and there are other mid-level providers as well. And it turned out to be very efficient. Now, this is a drive-through vaccination center, and so people stay in their cars. They're socially distanced. All the personnel are wearing masks. It's based on volunteers as vaccinators and also as staff, as well as some paid staff as well. So I have to say that at least that experience, was extremely positive. The folks that were getting the vaccines, were trained clinicians. They had to be licensed clinicians, and I think the reception was quite good.
Yeah, and I'd just like to add to that there's a lot of resources at the local and community level, a spirit of volunteerism, and we should have confidence in that system to stand these things up. And we're not in an altered standards of care situation in this setting. And so everybody should be medically qualified and confirmed credentialing and just-in-time training and overseeing by medical supervision and things like that as well. So we need to instill confidence in the system, even though it is a mass vaccination clinic. So the next question then is, what percentage of people don't show up to COVID-19 vaccine appointments? What are the rules regarding the resulting extra vaccines when people don't show up? I think Nathaniel, maybe you want to take a shot at that?
Yeah, I'll speak to that briefly. The first answer is I don't think that we have either state-based or national data on this. I can tell you from my personal experience, it winds up being, for example, if you have a high school auditorium or gym sized event for a day, in the times that I've taken a look at this, it's been something on the order of a couple of dozen people don't show up for one reason or another. And then the person who asked the question is right. There's a question of what you do. And what I have witnessed and what I've heard about is that there is a scramble to try to find people in the neighborhood who could come in rapidly to get the doses until they're all used up. This has led to bad outcomes in various locations when physicians administering the shots haven't been able to find people in either in the local area or in sufficient time, but we won't go into that. I do want to say this, if I could, Rob, just take a second to emphasize a point that Jack and Michael both made. One of the things that Jack said at the beginning was that there are sciences outside of public health and medicine that are critical here. And he's indicated one of them, which is mathematics, and another, which is supply chain engineering. The approach is so fundamentally different when you think about things from a different scientific perspective. I mean, just for example, this point that Michael was making of not just focusing on the person in front of you, but the fact that when you can administer one additional dose today, it's possible, if the system is flexible enough, that you can essentially pull every single person who had that spot in future days one day closer. However, if the system is not geared to have any flexibility of when those other vaccination days are scheduled, then that's just a lost opportunity. And I can tell you, again, from my personal experience in New York City, the systems that are out there have to rely on well-meaning individuals who are running them to have any flexibility once the vaccination appointment has been made. So we are talking about vast institutional information architectures that need to be updated and changed so that we can actually achieve the type of scale and efficiency that we're talking about.
Yeah,
I did want to make that point.
And I'll also add a personal reflection at the Mass Vaccination Center. I have been working at it, which is based on the available vaccine and filtered in the no show rate, or the ability to occasionally take on walk-ins and what they call plus ones. The plus ones are someone that are coming with other family members that have registered for the vaccine. They weren't eligible, but there's a little bit of additional vaccine available, and on that day they may be able to get the shot early, while on another day they may not be able to get the shot because of the availability of the vaccine.
Okay, I think what we'll move down to, here's a question. Given that a first vaccine, Pfizer or Moderna, locks in demand for a second dose at a designated future time, how do you account for the uncertainty in future supply amounts when deciding how many people to vaccinate today? Jack, I think you touched on that.
Yeah, my point is that you need to keep it going, and if you start running short, then subsequently you reduce the number of first doses so that but don't hold back now and crossing your fingers or something and saying, well, bad things are going to happen. Well, bad things will happen, but just remember, the goal is to get as many first shots in arms as possible, as soon as possible. And if you don't do that, ultimately it has a cascading effect on the number of people who are going to possibly spread the disease or get the disease. And so you want to avoid that by as much as possible. And the example I showed you earlier is that if you all of a sudden find out that you're going to be in trouble with supply, it's not a good idea to say, oh, gee whiz, I should have held this. Just do what you have to do on the day you have to do it. And that's the only way you can respond. Otherwise, I understand the point. And I'm not a medical doctor. As my son says to me, I'm not the kind of doctor who can do you any good. But in this particular case, I think my medical doctor friends would say that the risk is greater of not vaccinating somebody now than have to wait a day or two later to get the second shot. Am I correct in that, my real doctor friends here?
We would definitely concur with that.
I think that it's even more true with vaccines that require just one dose. I know one of the attendees was wondering about the need for 2 doses to reach the efficacy, and the vaccine, how that affects the vaccine days. I agree with that comment, but still, 1 dose is better than 2 for protecting this person, and certainly more true with 1 dose vaccines like the newly approved one.
Let me also say that the availability of the second dose is not so much the problem of the manufacturer. It's the problem with the distribution system. And the distribution system, if you just recall how I started this discussion off, has to have these 5 attributes. Understand the customer needs first, but you've got to have information infrastructure. You've got to have the processes in place that are going to acquire the information and then make decisions, the last point, in a way that is going to move the material to the spots where it's needed. So if you're going to run out, it's not likely in this instance to be because the manufacturer has not done its job. It's because we haven't put the blocking and tackling in place that's going to ensure that the system is going to function properly.
Now, how would you account for access? issues with some rural populations or minority populations that may not be able to get to these large sites,
Yeah.
larger, lesser
Can-
sites.
I mean,
Can
it's, you know, if we chose the state of New Hampshire, for example, for a reason. For those of you who are not in the United States, New Hampshire is a fairly small state. It's a very small part of the small state happens to be on the Atlantic Ocean. And that's where most of the people live in an area which is in the southeast portion of this. So it has a large rural area, geographically speaking, percentage of its space. So if you're going to have something that you do at scale, that has lots of people per day, so that you don't end up with supplies sitting on shelves in drugstores for an extended periods of time, you're going to have mobile clinics that are going to move, and you're going to run them in a particular area, maybe twice a week, in another area, 3 times a week or whatever. So some of these, unfortunately, the length of time we had to talk today didn't permit us to really just, develop all these ideas very fully. But ensuring that you get the coverage that you want is an absolute necessity. And so part of what you also need to do is to ensure what I would call the fairness part, which we didn't again address. Which parts do you want to give priority to? And again, that's not a question that we looked at, but the mathematics, if you can state some goals probabilistically, and you can then make allocations according to your goals that you have for each individual geographic region, and ensure that you can achieve those goals. So that's what the optimization technique does. It ensures that you achieve those goals in a way that creates the fairness part that I think is so important.
Thank you.
So again, just to chime in for a second, so a location does not need to be a physical location. It can be a mobile unit.
That's right.
And if that means we go to one rural area on one day, another one on the next, and so on, to make sure that we have sufficient numbers to make the
So it's
system
not
run
a-
efficiently, that's totally fine.
It's not a set of static locations necessarily.
Yeah. Let me just add one other thing, especially relating to this point about hard to reach or historically underserved communities, which might require not simply setting up a mass stadium. In each of these locations, the metrics that we've laid out are a way to assess fairness across different types of populations. And I think we all, the creators of this model, believe that it would be unfair for efforts to target these smaller communities to run afoul of these metrics and these lessons that we're learning about how to do this most efficiently. If you want to target community X, it does not make sense to create a vaccination system that's going to only get the vaccine into people's arms slowly or in a less efficient manner than community Y that has access to a large stadium. In the back of our minds, I think what we're saying is these really overarching priorities, vaccinate quicker rather than later, go bigger rather than smaller, need to be balanced against the really local needs and requirements and restrictions that public health officials on the ground will know about and will be able to bring to the table.
Right. And if Daniel, I'd just like to add to that. I mean, the importance of transparency within that system is very important to ensure that all communities are addressed equally. And that's been a high priority for us. So. Next question, Michael, we started talking about the mobile vaccine clinics. So with regard to the transportation problems for some people, how does a model of door-to-door mobile vaccinators fit into your model of larger sites being better, considering the mobile provider team to be a site? So we have discussed that extensively over time. So.
Yeah, so we're saying that, again, the mobile unit should definitely reach people. We care about people in rural areas. We care about vaccinating everyone as soon as possible. So if there are some units that that should go out to those areas and see those people, then we should do that. And if you know, it's the public health people, all the folks who are going to deal with the priorities. The other, you know, taking a step back as well, you know, in terms of the decisions that were made in terms of which groups are vaccinated first and which ones are second, you know, that's done on, we're going to do this day on this particular day versus the other, you know, the next day or the next week. And so those things, of course, we still want to do those efficiently. But when it comes down to seeing people in areas, you know, if it needs to be going out to various places, then that should be done. If the numbers are too low, there will be some efficiency issues that we might encounter. But the point is that we would want to minimize the number of that. So if in fact that particular group is of utmost importance to serve and give access to, which I believe access is extremely important to everyone, there may be some you know, things in the system where in that case we may not perform as well, you know, in terms of the metrics to be able to provide the appropriate access. And I would say that that's actually okay, but we don't want to do that for the entire system, right? That's the point. If we do it for the entire system, then we're going to have inefficiencies throughout. So we want to minimize the amount of you know, inefficiencies of distribution, but that's not at the cost of, that should not be at the cost of providing equal access to people. So this is something we all need to look at carefully, and as we continue to say, that what's happening should be transparent so everyone knows what's going on.
Now, if I may ask a question to Jack, actually, I know you talked about your pillars, and I really appreciate you listed them, and they're really wise and important. From looking at the current distribution of vaccines in the US, what constructive feedback would you offer just from your perspective and your years and years of experience in this area?
So you're right, years and years, that just means I'm old. So just recognize that the systems that we have in place do not adhere to my principles very closely. And as a consequence, and I don't want to make any political statements here. This is not a castigation of anybody or any group. It's just, and it's not unique to the system. You have to understand that. Yeah, I mean, there are very few supply chain systems that adhere to these principles. And I think it's fair to say that I will quote one of my favorite philosophers of the last century, at least, and maybe the current one, Clint Eastwood, who said, "A man's got to know his limitations." And the problem that we have in our world is that we have unique skills, but narrow ranges of skills. And the problems that are associated with the operation of complex supply chains requires a set of skills that are not typically found by people who are in the public health sector. I observed that when I was on this board of scientific counselors. You know, very competent people, but very limited knowledge of at least other people on the board of the intricacies and the imperatives associated with adhering to the principles that I've put forth. It's yeah, just remember, there's really an important message here. It's not so much about what we're doing today, because what we're doing today, we're not going to be able to correct very easily any deficiencies of serious consequence. The question is, what are we going to do as we build out systems across the world to deal with this kind of thing? Because it's going to happen, and it's going to happen more frequently, in my opinion. And hence, it's the essence of the response systems have to begin with what I've called the blocking and tackling. You got to do those things that I enumerated in the first, before you start to get to more other levels of trying to determine how you're going to best do things. In other words, the questions that we're asking about, well, how do I get to the people who are disabled or whatever, those are very important questions. but you're not going to be able to answer those questions properly if you haven't answered the bigger questions first. First pants, then shoes. Get things in the right order. You got to be able to structure your system in a way that's going to be able to respond. And if you don't do that, if you don't do the principles first, adhere to the principles first, you're not going to get satisfactory answers to the other questions either.
Can I
Thank you.
just jump in
Okay.
one second? This is, as Jack said, part of a much larger issue, and it was an issue that was dealt with in a 3-year committee for the National Academies that just released its report actually in June. I happen to be on that committee, so this is a plug for anyone interested to take a look at it. It was a committee that was specifically looking at the evidence base for public health emergency preparedness. It was commissioned by the CDC, and one of the conclusions was that there is essentially a missing national research plan for incorporating these types of non-medical, non-public health sciences into a holistic effort to provide the evidence base for the types of things that we're talking about today. This is one small piece of that, but it is a very large picture, and it's a picture that currently is lacking an NIH institute to support it.
Yeah, if you look at the tasks that the federal government is asked to respond through FEMA and other organizations, very often these are incidents that arise, such as hurricanes, floods, fires, these kinds of things. And they have, those kinds of things have a certain set of attributes associated with them. And let me just enumerate a couple. They tend to be localized. They tend to arise sometimes suddenly. Even in hurricanes, you know the hurricane season is going to occur, but you don't know exactly how many, where it's going to strike exactly. So the information about the end effect of that is delayed, and you have to respond to it fairly quickly. But those incidents come and they go relatively quickly. This particular problem is different in scope. It's a national problem. Every sector of the country is affected, whether it's Alaska, Maine, or Hawaii, or Florida. Every corner of the country is affected. And it's affected for a long time. Secondly, you have more time to prepare than you do in the other ones. Instead of days, say for a hurricane, you have months. So the way you design the system to build up and the kinds of skills you have to develop, it's different than you have for other kinds of emergencies. Now, that all said, the 5 principles still underlie all this. Just know what the requirements are. So you have, my years of consulting, and I tried to give the talk this way, it's more about asking questions than it is about getting answers. And the mathematics is not about necessarily providing answers. It's probing you and pushing you to understand the right questions that need to be addressed and forcing you to think deeply about those questions and the consequences of what the mathematics says. So that's, in my opinion, even more important than the answers.
That's a great message, Jack. Thank you. I'll turn it back to Dr. Wax.
Okay, well, I'd like to thank our speakers today for really a superb presentation. I do want to quickly address a couple of the questions in the queue, generally about vaccinations and vaccinators. Pharmacists are also vaccinators. I want to make that clear. And it really depends on state licensing, but there are a variety of clinicians and pharmacists, are actively vaccinating. In terms of if you have asymptomatic COVID, can you get the vaccine? The current CDC recommendations is that if you no longer need to be in isolation, you can get the vaccine. And the isolation recommendations remain that there's been at least 10 days that have passed since symptom onset, and that you're at least 24 hours since resolution of fever. So if you meet that criteria, you can get the vaccine, unless you got the monoclonal antibodies or any of the transfused antibodies. In that case, you have to wait 90 days. So and if you've been treated with that sort of treatment, you wait 90 days. Otherwise, is within 10 days of onset of symptoms or a positive test, you can get the vaccine, as long as you don't have a fever. So at this point, if we could go to the next slide, please. So we're going to be continuing our webinar series next week with a look at long-term care facilities. It should be a very interesting presentation, looking back over the challenges of the past year and looking forward to both challenges and opportunities. And we have two distinguished folks who work in this field who are going to be delivering the presentation. We also are going to have an update from the front lines in Israel, where sounds like they've vaccinated more folks per capita than any country around, and they'll present some interesting data about their challenges and their successes. So that's next Wednesday, March 17th at 3 p.m. Eastern Time. Next slide. The full compendium of webinars can be found on our series prospectus, which is available on our website. Feel free to view any of these past webinars. Feel free to communicate with us at info@acmt.net for future webinar suggestions. We hope to continue this webinar series certainly for the next several months. Thanks again to our speakers and our panelists. Everyone have a good day.
Thank you.
Thank you.